Perfect. So can we go to the next slide? Perfect. And next slide, please. And next slide. Okay, so this is something that I need all of us to know when we talk about lung cancer screening. Remember, we gave the cigarettes to the people to smoke because it was a reportable condition 100 years back, 100 or more years back. In 1912, there were only 374 cases, and we have done it. We have done this for everyone. So just remember that when you're telling your patients to stop smoking, a lot of it has been done by us, and we have given them cigarettes. Next slide, please. Okay, so at a glance, at all stages of lung cancer, what is your 5-year survival? It's dismal, 26.7%. This is much worse than any other cancer, and this is why lung cancer screening is so important. Next slide, please. You can look at the number of new cases, right, of lung cancer. We are 234,000 approximately, and these are the latest statistics. And if you look at other cancers, you're going to say, oh, breast cancer supersedes everything. So does prostate cancer. Why do we care about lung cancer? But look at our mortality, right? Our mortality is much higher in lung cancer, and we represent only 11% of the new cancers diagnosed every year. But unfortunately, we represent the highest mortality of cancer. So hence lung cancer screening is important, and unfortunately it's also in a stigmatized population, right? We are doing it only for those who smoke cigarettes. So this becomes a double whammy for our patients. Next slide, please. So what are we following as guidelines for lung cancer screening? Currently, we are following the most recent USPS, that is United States Preventive Services Task Force recommendation. This was a recommendation that they came up in 2021. The article is listed below. It came in JAMA. And they said that we need to now scan people who are aged 50 to 80 who have at least a 20 pack year history of smoking. So, what does that mean? It means you smoke half a pack a day for 40 years, or you smoke a pack a day for 20 years, or a combination thereof, right? That's why you never ask patients, what are you smoking now? You ask them, what is the maximum you've smoked? How many years did you smoke that? When you cut back, how many years were you cutting back to this? And when did you stop is very important currently for lung cancer screening, because currently we say within the past 15 years. I'll show you data on why that is going to go away and why the NCC and the National Comprehensive Cancer Network changed their guidelines to say indefinite. You smoke 20 pack years, it doesn't matter when you quit, we need to screen you. But unfortunately, that is not yet widespread. Next slide, please. So, why are we worried? Because lung cancer means different things to different races. So, if you look at the relative 5-year survivals of cancer by race and stage of diagnosis, and this is specifically in the lung and bronchus, you're seeing that the green is the white, and the black population is represented by the blue, the dark blue. And what I want you to see is that in early stages is much more predominant in the white population, and later stages it becomes higher in slightly higher in the black population, and they are much more sensitive to the number of cigarettes smoked. So one cigarette that a black person smokes is equivalent to about 5 cigarettes that a white person smokes. So they are much more sensitive to the carcinogenic effects of cigarettes than the white population. So that is a problem. And if you look at it, definitely in terms of the cancers by race, unfortunately, again, the number of deaths and the number of distant metastatic disease is much more in the black population. So basically to say that the black population presents with later stages they are much more sensitive to cigarette smoking. So these kind of nuances is what is being taken into consideration when we are changing the guidelines. Next slide, please. Now, this may seem like a confusing slide, but I want to spend some time talking about this again. Now, the current USPSTF guidelines is where you see that big block arrow, and if you see the asterisk or the star, that is the expanded USPSTF guidelines. Now, the current guidelines basically captures the white population more. It does capture the Black population and the Hispanic population and the Asian population, but definitely more of a capture of the white population. And there is a discrepancy here in the number of patients being captured. Now, if you look at it with the expanded, this is men and this is women. If you look at it with the expanded guidelines, that means we say age 50, you have smoked 20-pack history of smoking, but let's push out the years you stopped smoking to 25 instead of 15. If you do that, you're capturing more of the Black population. You are capturing more of the Hispanic population. And that is what is hugely important. And that is why NCCN has gone to no quit date at all. And the same holds true for women. And if anything, in women, it is a little bit more, it's not as pronounced as the men, but it is still there. These racial differences still exist. And that is why it is important for us to think through why we are doing it. Again, remember, this is only for people who smoke cigarettes, not for vaping, not for chewing tobacco, not for cigars, not for cigarillos, not for hookah, not for black and mild cigars. So it's a very important thing to remember as to what we are trying to do. Next slide, please. So why is this important, right? And we talked about it. There are a lot of socio-economic factors that are playing into lung cancer. As you know, cigarette smoking is the leading cause of lung cancer deaths in the United States. But you know what? Non-smoking lung cancer has now become the 7th leading cause of death. So we have to keep that in mind also in the back of our head. And we know that tobacco product use is just more prevalent in adults who are uninsured, enrolled in Medicaid, or who have some other public insurance, compared to people who can afford insurance and have more private insurance. And we also know that if your family income is low, then you have a higher incidence of lung cancer because of all the prevalent behaviors of tobacco use and other things that could be there in their environment. Next slide, please. So why are we screening? We are screening because it's a high prevalence in a high risk population, which is the current population of people who smoke cigarettes. The 5-year survival rate, as I told you, is pretty dismal. However, if it's stage 1A, we are better. We are inching towards, some studies have shown even up to 90% in stage 1A cancer, which means a very early stage of cancer, less than 3 centimeters with no lymph nodes. That is what is called as stage 1A cancer, and that is great. But only 15% of lung cancers are diagnosed at early stage. Hence, we are all touting lung cancer screening, November Lung Cancer Awareness Month. We need to get screened if you fit the bill of the population who is at high risk currently. Next slide, please. So the 2 big studies that pushed this were the National Lung Cancer Screening Trial, or the NLST, that was done in the US. The European trial was Nelson. In both the trials, they had pretty decent number of population, 26,000 for the NLST, and we had about 15,000 in the Nelson group. And for the NLST, it was age 55 to 77, and it was 30-pack year history of smoking. And the relative risk reduction from mortality from lung cancer with low dose CT screening was about 20%. In the Nelson trial, they included younger patients, 50 to 75. They said if they had at least a 15-pack-year history of smoking, and if they stopped within the past 20 years, then they had a much higher risk reduction actually in the Nelson trial as compared to the NLST. And it was 26% in the Nelson trial. And Nelson trial also showed that in women, the risk reduction was much higher than the men. So what it's trying to tell you is our population is about right now 50 to 77 to 80, depending on how generous the insurance is, and about a 20-pack-year history of smoking. So there's a reason we have come down to 20-pack-years, as I told you before. And it is important, and there have been studies which are done on this. And what is a low-dose CAT scan? A low-dose CAT scan is a regular CAT scan which uses a low radiation dose of 1.2 millisievert. What does that mean? It means it's lesser than your background radiation. If you go around walking anywhere in Baltimore or wherever you live, in a year, you get about 1.5 millisieverts just by walking outside. In a low dose CAT scan, the radiation is less than the background radiation. So that's what it means. It means that they are going to take cuts of the lungs. They're not going to have the details of the lung parenchyma, but you will be able to see nodules. And it should extend always to the level of the adrenals, because lung cancer always goes down, goes to the adrenal glands when it metastasizes. Next slide, please. So there's a lot of things, right? We talked about the eligibility. Now, shared decision making. We talked about the LDCT. There is a structured reporting for lung cancer screening, and you'll find it as lung RADS. I'm just going to mention to you about lung RADS if I don't find it in the next couple of slides. Tobacco health and tobacco treatment, tobacco use treatment is an integral part of lung cancer screening. Doing only the screening without addressing tobacco treatment is not good, and I have some data to support that. And it is important to have a database when you're doing lung cancer screening, because you need to keep on top of when the patient's due for their next CT. You need to have a multidisciplinary governance. That means you need to have different specialties there looking at nodules to decide what are you going to do with nodules. And there are some false positive rates. Next slide, please. Perfect. Now, this is a very, very good website, shouldiScreen.com. It is done by University of Michigan. And if you actually click on the link, you can actually go through an extensive 12-question review, and it shows you pictorially what kind of risk you have for lung cancer. So if it is based on the age, demographics, it's based on whether you have known COPD or not, whether you have any known cancer, whether you have any family history of cancer, what is your education level, what is your BMI, and all of those aspects are included in it. And why is that important? Because there have been several risk models which have been looked at, and they have said that some of these components are also important towards informing lung cancer risk. So it's not just the cigarette smoking, there's more to it than just cigarette smoking. So hence it's a very nice one, and it is important to have that shared decision making. It's important to sit down and document it too. You don't have shared decision making, you're not going to be able to pay for it. Shared decision making can be done by an MA, can be done by a nurse, can be done by anyone. It does not have to be a provider. But the shared decision making has to be documented before you order an LDCT, and you have to inform the veteran that they are at high risk, they are eligible for lung cancer screening. You tell them about the false positive rates, you tell them about the radiation, and you tell them it is not one and done. Every year you need to undergo the screening. Next slide, please. So as much as it's important to know who to screen, you also need to know who not to screen. So the minute you turn beyond 80, 81 years old, and again, this is by the USPSTF guidelines, Medicare has some different guidelines, you stop screening. If they have not smoked currently for 15 years or more, like up to 15 years, if it's less than 15 years, we include them in screening, but 15 or more, we do not include them in lung cancer screening currently. If they develop a health problem that makes them unwilling or unable to have surgery if early stage lung cancer is found, then that's not a good idea to screen them. What does that mean? It means, supposing you have a patient and that patient is suddenly now on oxygen, has developed heart failure, has developed renal failure, that is not a patient you can screen, because not only that person is not going to be really eligible for early stage lung cancer treatment. Currently, the only treatment available is surgery. There is a big trial going on in the VA where we are looking head-to-head comparison of surgery versus radiation. But even for a person to undergo radiation, you have to be in good functional status. You have to be able to lie down on that table for 6 days in a week, and you have to be able to lie down flat. So there are many nuances to this. So if your patient is on 5 liters of oxygen, you really need to think about, do you really screen them? And then if they have an active infection or something, please don't screen them, because you're going to get all kinds of false positive results. If they have any active cancer which is being treated actively and not in remission for the past 2 years, please do not screen them, except for prostate stage 4. Except for prostate and breast, which can be screened up to stage 4. But other cancers, please don't do it. Head and neck cancers, don't do it, because there's high risk of false positive results. Next slide, please. So this chart tells you what is our USPSTF recommendation and what the Medicare thinks that they should cover, right? So currently right now in 2024 November, Medicare covers current or former smokers who have quit within the past 15 years, age 50 to 77. They are not taking it up to 80, and 20 pack years history of smoking, right? So that is what they are recommending. USPSTF recommends up to age 80, but Medicare is not recommending it. Hence, you may have a problem with 78, 79, and 80, that age group. Next slide, please. So again, this is what we talked about. But remember that nearly all our private insurances follow Medicare. And if there is something abnormal, like you find a nodule and the nodule is 8 millimeter, which usually means it's a higher stage in lung RADS, which means it's a nodule of interest now, and you need to do a PET CT or you need to do a CT in 3 months. Now that does not go under lung cancer screening. That goes under a regular CT. So if you try to order another lung cancer screening CT in 3 months, it will get denied. So you have to order it as a regular CT or a PET CT for follow-up of an abnormal nodule. And the patients will have a copay or deductible for that. So basically right now under Medicare, it allows one screening scan per year. Is this right? No. Should we do something about it? Yes. But at the present time, we are going to pick our battles. We just need to know how to make sure that our patients get the best care, right? So at least that if they get their LDCT, and if they find no nodules, that's great. That's lung RADS 1. If they find a really small nodule, less than 6 millimeter, that's also great, because that's just an annual CAT scan. So lung RADS 1 and 2 are considered as negative findings on CT, whereas lung RADS 3 and 4 are nodules of interest that you do need to follow. And if you are not comfortable following it as primary providers, family medicine, that is a nodule you can refer to your pulmonary colleagues or to a specialized lung cancer screening program. Next slide, please. Now, I told you that stopping smoking is the most important part of lung cancer screening. So this is very, very important because the 5-year survival rate for patients age 65 with early stage non-small cell lung cancer. And most of these lung cancers we are trying to detect with lung cancer screening are the non-small cell lung cancers, which are not considered as aggressive as the 15% small cell lung cancer, which usually presents with brain metastasis. So we are talking about non-small cell lung cancer. And the patients who quit smoking, the survival rate for them is 70% in age 65. Okay. But the patients who continue to smoke, the survival rate is only 33% in 5 years. So you're looking at such a big difference in the survival rate of early stage lung cancer between smokers and non-smokers. And the combination of stopping smoking for 15 years and lung cancer screening, that results in a 38% reduction in cancer specific mortality. And that's huge. That's huge. Next slide, please. Now, there is a lot of things in this slide, but I want you all to pay attention to a couple of things. 77% of the patients in the NLST trial continue to smoke even after 3 rounds of lung cancer screening. So the fact that you're doing lung cancer screening doesn't deter people from stopping smoking, because as we know, smoking is actually a chronic disease. It's not something you can just take a whim and say, I'm going to quit today. It's not going to happen. And there is no effect at all of just lung cancer screening on stopping smoking. I want you to look at this third bullet. The NLST participants who were current smokers at the time of enrollment in the LDCT had a 2-fold increase in the lung cancer mortality. 2-fold increase. That's huge. Former smokers who were part of this NLST, and NLST was low dose CT versus X-ray. So people who stopped smoking for 7 years and who got an X-ray instead of a low dose CAT scan had the same reduction in mortality as those who got the CAT scan. That is a 20% risk reduction. So it is important to know that the stopping smoking is a huge effect on lung cancer mortality. So doing lung cancer screening without equally doing tobacco treatment is like being half pregnant. And according to me, you can never be half pregnant. And patients who received intensive smoking cessation interventions, that means they got medications, somebody is following them, and those patients really did better in NLST compared to the others. Next slide, please. I think I'm missing some percentages there. Now, what is false positive? Now, if you have, and I've often seen this both in university and in the VA, a patient is coming to the emergency room for something else, and ED says, oh, they're due for lung cancer screening. Let's just do a lung cancer screening while they're there in the ED, but they're coming for some maybe cough, abdominal pain, something else. You get all these false positive nodules. And then you go into the circle of following those nodules, because you cannot not follow the nodules. Or you'll get areas of pneumonia, or you can get a pneumothorax, or you can get something else. My best one was a thoracic aortic aneurysm, which was close to rupture. Now, this is not what we want to do, right? So in the NLST, the false positive rate was 24%, and then it decreased, and then it increased in the second round, but decreased in the third round. The problem with NLST is at that time it had a much, they called any nodule greater than 4 millimeter as positive, which was wrong. And that was the problem why they had so many false positive. So now we have changed everything. We have a November 22 lung cancer, lung grads version 2.0, and that is what we are using, and that decreases our false positive rate. So I would say that now our false positive rates would be less than 12%. And it all depends on who is reading these scans, right? All of us in pulmonary read our own scans. So even if the radiologist has said something, we look at our own scans because we see the patient and they don't know all the nuances of the patient. Next slide, please. Now, why are we harping about lung cancer screening? Because unlike any other screening, look at the adherence for breast and colorectal. It's 76% and 76 to 81% and 59 to 65%. And lung cancer screening is so bad. We are at 28 to 38% in academic centers. Academic centers. But everywhere, if you look at it, it's really, really bad, right? That's why there was an article on USA Today. Why are so few getting a CAT scan? It's because of the stigma. We are the only screening program, colorectal cancer screening. What do we call it? Colonoscopy. Breast cancer screening. What do we call it? Mammography. Do we mention cancer anywhere? No. But we have decided to call this lung cancer screening, and automatically that deters people. We need to change the language. We need to change it. In fact, I was just talking to someone from Genentech the other day when we were in the VA having our table, and they were saying that they were driving in South Carolina, and someone, they called it a lungogram, right? Like a mammogram, right? Or I call it often lung health screening in the VA, because if you use a less stigmatizing language, your patient is not going to get petrified. I mean, though patients know that you're doing a mammogram to rule out breast cancer, they don't, the stigma is not like, I mean, it's cancer is not in their face. And that is a very important factor. And we actually don't believe in it ourselves. So that's also a factor, as I'll show you in the next few slides. Next slide, please. I'm just going to talk to you about the barriers of lung cancer screening. Next slide, please. So this is trying to look at the county level map of Maryland, and there are two different things. This goes by the amount of percentage of people who are smoking, the darkest one being the highest percentage, where 20.3 to 42.8% of people who are smoking. And as you can see in Maryland, it's kind of much more in Western Maryland. It is not as bad, surprisingly, except for a small spot, which is Baltimore City. And then this looks like the access to care, to lung cancer screening, right? Like how many people have access to lung cancer screening. So no barriers to access is this column. And in Maryland, in the state of Maryland, we don't have too many barriers to access. You can look at other states where they have barriers to access and they really do not have much access, or you have to travel much longer, more than 40 miles to get to a lung cancer screening center. This looks at mortality rates, and the lighter is less mortality, darker is more mortality, and again, access to lung cancer screening. Again, in the state of Maryland, we are not too bad. So our access to lung cancer screening in the state of Maryland by county level is not too bad. We do have access to lung cancer screening compared to other states. Next slide, please. The follow-up of lung cancer screening really drops off, and that is the messaging, right? So we need to tell people, you're getting your first lung cancer screening today. I need to see you back in 12 months. I'm going to get you an appointment now before you leave me for 12 months. And unfortunately, that is where you're going to find the cancers. You don't find the cancers at the incident LDCT. You invariably find them in the follow-up LDCTs. Next slide, please. Now, these are patient perspectives, and I love this article in Chest, and that's why I'm sharing it with you. So patients who underwent lung cancer screening, right? And they had positive experiences. They said, like, I think it's pretty easy, right? Like you just go, you lie down on a scanner, it takes 30 seconds and you're out. It wasn't a hardship. It's not invasive. It's not embarrassing, because as a lot of us women will tell you, going for a mammogram becomes like heart palpitations, at least for me, because you're going to get crushed. And so it's positive. So the people who engage in lung cancer screening have very positive things to say about it. Next slide, please. But then at the same time, I don't think that they truly understand what is the meaning of lung cancer and how asymptomatic cancer screening is a thing, right? They seem to understand it for a mammogram and they seem to understand it for a colonoscopy, but they think that in the lung, if there's something going on, then it's their fault. First of all, like uh, my family was in the body and fender business. I was breathing a lot of stuff, and I'm breathing a whole lot of stuff that I shouldn't be breathing, and I smoke cigarettes, so I'm going to get lung cancer. Is that making sense? It's like self victimization, right? And older I get, the higher risk of cancer. If I had cancer and I had a symptom, maybe I'll get screened, but you're not going to have symptoms till late stage, till stage 3 and 4 of lung cancer. Remember this, please. Stage 1 and 2, early stage lung cancers, do not have any symptoms. Next slide, please. And the cost, right? Because again, I do not understand still today, because still today I'm told that the Medicaid covers lung cancer screening. But if you look at our patients, right, our patients sometimes on Medicaid have gone to multiple hospitals for multiple issues. So a lot of times when we got these prior authorization calls, when I went to CRISP, and if I was lucky, I would find what CT scan was done. Any CT chest, CTPE protocol, CT angio, which includes the whole chest, all, or a regular CT chest without contrast, all that substitutes for lung cancer screening. Please do not order duplicate CTs for lung cancer. You can have the radiologist look at that CT and say, what do you think? My patient is a part of lung cancer screening. Is there anything you can tell me based on these? Because they're not going to read it as lung rags, because they didn't think about it as lung cancer screening, but it does meet criteria for lung cancer screening. So please do not duplicate scan them either, because your insurance is going to come after you. And this is what writes some of the costs for the insurance. And also, how do you go there, right? I don't have transportation. I have to budget for myself. It's so difficult to go. But you know what? It's once a year. Everything can be done once a year. Next slide, please. And other concerns, right? Like when they say, okay, I have breast cancer now. So that's more important than lung cancer screening. And actually, if you're looking at the mortality, lung cancer will kill you faster than breast cancer. There have been many people who are survivors of breast cancer for 20 and 30 years, even if their stage is slightly higher, but you cannot say that for lung cancer, unfortunately. So it is a problem. Or if they have a knee surgery, they say that's more important than getting lung cancer screening. It's because we as providers are not kind of telling them how important this is. Next slide, please. So these are barriers to lung cancer screening. This was a very neat study done at UNC, and they looked at primary care. They looked at both internal medicine and family medicine, and they looked at what is the provider perspectives on lung cancer screening. So what did they find? So the number one thing that deterred the providers from getting their patients to lung cancer screening was a cost to the patient, right? And you can see other barriers like too many false positive, there's emotional harm, potential for complications, cost to the healthcare system, so on, lack of effectiveness. And then they felt that they really did not truly understand what exactly lung cancer screening is. How does it really benefit the patient? They didn't have a good interaction with they didn't have a good collaboration with a lung cancer screening program, which told them what does it mean if your patient has had this result in lung cancer screening. And they really felt that it was very traumatic for our patients, and and many other things like cost prohibitive, transportation prohibitive, and many other things. But the basic thing remains, people do not understand how lung cancer screening can save lives. It's a CAT scan once a year. It's not the end of the world. If you come to the ED with anything, even a slight sniffle and cough, you're getting a CAT scan. It's one CAT scan once a year. Next slide, please. The system barriers, right? And I have dealt with a lot of this in system, because who is responsible for lung cancer screening? Currently, in many places, they have this epic lung cancer screening database, okay? But who's really responsible for this? Do we have the funds to have someone to be daily looking at that entire list and saying, oh, these people are overdue, let me call them, let me make sure that you have follow-up, let me make sure that it's easy for you to get scheduled instead of waiting on the radiology scheduling for 2 hours, right? There has to be some kind of navigator or someone else who can do it. In the VA, we have an excellent system to do it, but the VA funded it. Unfortunately, that is not true for many places, right? And you need to enhance care coordination. Like if the primary care orders it, then they have to be responsible for the findings, or they need to reach out to people and find out. And they have so many patients on their roster of patients. They're not going to have the time to do the nitty gritty doing. And remember, lung cancer screening CTs will find you emphysema, it will find you fibrotic lung disease, it's going to find you coronary calcification and cardiac disease, it's going to find you aortic aneurysms, it may find you pulmonary hypertension, it may find you thyroid nodules, it may find you renal nodules, it may find you bone thinning and potential for osteoporosis, it will find you hepatic steatosis, it will find you a lot of things beyond just lung nodules. So it's very important that there is a collaborative effort on this. And automatic EHR is great, but it needs a person or a couple of people to be running that database. Having an EHR without having the second component is not at all good, and you get yourself prone to problems. And then you want to create data metrics, right? Are you screening? But are you just looking at incident screening? What is your follow-up rate? How many of these patients are getting lung grafts 3 and 4? And all of those things are important. Next slide, please. So this is my last slide. Basically, I think I've impressed on you that current guidelines, age 50 to 80, and depending on Medicare, 50 to 77, 20-pack history of smoking, current smokers or quit within the past 15 years, you have to do shared decision making, and you need to document it. Doing lung cancer screening without writing out shared decision making is incorrect, and your patients can get a big bill. There are false positive results, but it's not that bad anymore. And there are a lot of automated AI systems which are looking at nodules, and they have gotten better and better at looking at real nodules versus something which is not really a nodule. And barriers exist, and we sometimes, as providers, as healthcare workers, can be the barriers ourselves too. So we need to embrace this screening as everyone else embraces it. And we need to start having champions for lung cancer screening. Next slide, please. That's it. Any questions? And that's my email address. Thank you so much for having me.